Many people in Ghana have had bad experience at the hand of a nurse, midwife, or other health workers. Many of these cases changed the lives of the victims for the better or worse. On many occasions, the repercussions are dire. Some victims never live to tell their story. In sub-Saharan Africa and Ghana in particular, women still die in childbirth. This is unacceptable. To reverse this trend and promote safe pregnancy and labor, the Ministry of Health, Ghana Health Service and other stakeholders have introduced several measures. But how many have worked? About 130 million babies are born annually. Of this number, over 3 million die within the first 4 weeks of life, and another 4 million are stillborn, and these babies are not counted, and their families grieve in silence. We can bring joy to families if we promote maternal, infant, and child survival with excellence. Let us all promise to save lives. These are the words of the current Greater Accra Regional Director of Health, Dr. Linda Vanutu, who has done so many things to make sure that this dream is realized. These figures, has anything changed?
Thank you very much. We realize that over the years, a lot of effort has been put into saving mothers and babies. And I'm sure you are aware of the Millennium Development Goals that specifically looked at reducing maternal deaths and also reducing child deaths. And because of that, countries all over the world, communities, facilities put in so much into reducing these deaths, which unfortunately occur. So we realize that there has been some reduction, and Ghana is one of the countries that also committed to ensuring that maternal mortality is reduced and child mortality is also reduced. So some work has been done.
So I promised myself to find out more. My journey to know more started with an encounter with a young midwife in charge of one of the CHIPS compounds in the Shai Osudoku district. Comfort Abire told me she squats with women in labor because they refuse to go the conventional way.
At my place and here like this, most of them come in labor preferring the squatting position. So when they go in labor, you also go in labor. We squat with them for them to put their hands on our knees. And then they hold you, they use you as a firm support, and then they can push.
Then I learn about how peculiar the Shai Osudoku district is. It is part of 16 metropolis, municipalities and districts that make the Greater Accra region. It is the largest district in the region, located on the southeastern part of Ghana. It has a land size of 1,522 square kilometers.
Our district is huge. Yes, it's huge. 60,971 population. This population is a population of a sub-district of another smaller district. So they have to walk distances, and you don't have money to give them. You don't have motorbikes to give them. But I'm really proud of the teams.
Health needs of the people here are like any other across the country. Fortunately, there is a twist to the situation at Shai Osudoku district.
At the same time, family planning now time there will be until I have it.
I learned for the first time that nurses move from house to house to attend to the health needs of residents. Key among the targets of the Health Directorate here is to ensure that no woman loses her life giving birth. Dr. Kennedy Brightson is the medical superintendent of the Shai Osudoku District Hospital.
Okay, so the post-operative cases, they are here. But like I'll say, we don't reject patients. So we have patients on the floor. We have patients on the floor. We do not say that we don't have beds. So when you look at it, it's a student's mattress, and we got 10 from NADMO in Dodo, National Disaster Management Organization. Mr. Ajakli was kind enough to us. We called him. He gave us this. These are post-op cases. We just finished operating them. You know, this was the first case, right? Okay. So this is on the floor. We would manage. When I wake up from home and I'm going to the hospital, there is one prayer I offer. And it's like people ask me, so do you pray? I say, I don't pray a lot. I just have a short prayer. So one day I was asked, what prayer is that? I said, God, use me again today to save as many as you want to save.
What a powerful prayer. I like the prayer. It's so short.
It finished. A lot of pastors have been receiving them. And it becomes a big problem. So they go for prayers, they don't come for clinicals. But when the prayers get to the peak and what they are expecting does not happen, and death begins to stare at them, then they are rushed to the hospital. We save them. We save them. But we suffer to save them.
Like Dr. Brightson, the Greater Accra Regional Director of Health has her own promise. In 2008, Dr. Linda Amaka Ivanotu developed the PROMISE model. The PROMISE stands for Promote Maternal and Infant Survival Excellence. It was developed out of a desire to identify the reasons for the high number of stillbirths and maternal deaths recorded in the western region of Ghana, where she was the then Regional Director of Health.
So as a regional director, with my team, we had to find out why these babies and mothers were not surviving pregnancy. So what we decided to do is what we call the PROMISE. And PROMISE basically is ensuring that we offer care to pregnant women and their babies, and also involve the families and the community as best as we can. And one of the things that we did was to have what we call the PROMISE drivers. Okay. You know, we've always talked about the 3 delays that contribute to maternal death, that contribute to child death. The delay in the person seeking care, the delay in getting to the health facility, and the delay in giving the care when they have gotten to the health facility. But I realized that there are other things that come in, and it starts even before somebody becomes pregnant. So we're talking about nutrition, we're talking about family planning, we're talking about adolescent health. Because if you want to have a baby, then you must be prepared for it. Yes. If you don't want to have a baby, you should prevent it. So we look at that. We also look at, if the mother comes to the antenatal, what can we do? We need to assess every woman, every pregnancy as one. The fact that I've had 2 children before doesn't mean that when I come, you should just assume that things are the same. So now what we do is that we try to look at these babies, these mothers, as individuals. We need to look at our statistics. We need to look at the data that we are churning out. We need to look at where we are doing well, where we are not doing well in terms of our audit. We need to have blood available. And then we also need to link public health and clinical care together, because that is the whole health. We cannot do one and leave the other. So we need to do it together. We need to be able to refer. And if we are referring, the place where we are referring to must know that we are referring somebody, and the one we are referring also have to understand why they are going to the next level. Sometimes people are afraid that it means my condition is going to kill me, but it's because of the level of care and what you need to help you to come out with a good pregnancy and pregnancy outcome. And then we also need to mobilize resources. We cannot use what we receive in health alone. There are people who offer care within the communities. There are people who can contribute towards health care within the community. So we need to look at where we can get resources and then prudently manage them to be able to give the best of care. And then we also have to monitor, evaluate, and even conduct research on the work that we do. And then the most important thing, we need to involve the community. So the promise drivers that I am talking about are a set of 12 things that we can do. Each driver has more than one thing in it, and there are several activities. But inside, in the middle, is the community. And the community, we are talking about the pregnant woman herself, we're talking about the spouse, we are talking about the family, we are talking about the systems that exist within the community, which we can use to enhance our health care. And the key thing with the promise is that wherever you are working, you look at your own situation. You look at the kind of things you have around you. You look at the cases that come to you. You look at your capacity. You look at the people that you are working with.
That is from the side of the healthcare.
Yes, the healthcare, yes. And then you design strategy to implement activities that will help you.
Today, she is implementing the promise in the Greater Accra region, and it is catching on like wildfire. One of the modules of the promise is the pregnancy school.
What we do is that we hold meetings with the pregnant women and the spouses or anybody else who matters in that pregnancy.
Okay.
So it could be your mother.
Stakeholders of the pregnancy.
Yes. Because these pregnant women, as somebody said, hear a lot of voices. The voice from the Ghana Health Service, the voice from another person, the voice from another provider, the voice from even the media where people are talking about issues. And this pregnant woman can be confused and she may not have an opportunity to even ask anybody. So we organize these pregnancy schools outside the antenatal. There you can bring your husband, you can bring somebody else. And we present something, you ask questions. We also do it we have 3 trimesters because pregnancy is 9 months. So the first 3 months, the second 3 months, the third 3 months. And what we're trying to do is to bring in innovations as we go along. So for now, we have the first trimester, the second trimester, and the third one, so that we target our education. So if you come and you are in the third trimester, you are getting, yes.
What is specifically
for you?
That?
Yes, because you are getting close to delivery. So you must be prepared. You should know what to tell you that I'm in labor. You should know what you should do. You should know how to handle the baby. And if you are in the first 3 months of your pregnancy, you may be vomiting. And that will be your challenge. How do I handle
life challenges?
Yes.
It's good to put them
Yes.
in one class and
yes.
then you address them.
And then we address them. So if you have your husband come in, he can also ask questions. We also use the pregnancy school to do some couple counseling. If you have something that both of you don't understand, that's an opportunity for you. It is important to do this because at the regular antenatal, we have so many people, the nurses are overwhelmed, and there's no space. Yes, right. And since the people come early, we want them to finish and go home so that they can go and continue with their work. So the pregnancy school is an opportunity for you to learn about pregnancy, for you to ask questions, and if you've heard anything, you also, and then it also affords the midwives to know their clients better. Okay. And if there's any client who has a particular need, then they can address that particular need. If it is held within a hospital, then we use the opportunity to take them round the hospital. Some people are afraid of the labor ward or the theater and the rest. Yes, so we talk about it, and you can even peep into the theater. You will not go in there, but you stand out, you look and see that it is nothing like what you have heard. and the labor ward too, the men have an opportunity to go inside the labor ward, and they are told how delivery is conducted and all that. Yes, if we have any videos, we can also show them, and we teach them about the care of the newborn. So the pregnancy school used for many things.
In 2012, we realized that our stillbirth data, stillbirth rate was going up, especially with macerated stillbirth. So we did a retrospective study, and it was heartbreaking when we saw the reasons why they have lost their babies. I mean, some mothers have their babies in their wombs for 4 days. They don't even know that the baby is gone because they don't even know about kick count. They don't even have the knowledge to actually know that the child was gone. So when we looked at, realized that no, I mean, some died and lost their babies because they refused to do cesarean sessions. They were afraid. So they had gone home, gone to a TBA or an auntie, or gone to a prayer camp, and then 3 days after they came back. Then after looking at, realized that it would be good to have a pregnancy school. You see, the concept of focused antenatal care, that's what we do in Ghana. That's where the pregnant woman has a midwife who attends to her from beginning to end. But it's an excellent idea. But the downside of it is that the time, because you have like 260, 100 cases starting from 6 a.m. They come to say that service starts at 8, then they close at, even if you close at 4. You can't spend more than 10 minutes or 15 minutes with one exactly. So what the focused antenatal care has to do cannot be done not because the staff are not good or they don't want to do it, but the numbers. And as a pregnant woman, you come early at 6 o'clock, you are leaving around 12. I mean, when they get to you, you are tired, you are hungry, you just want to go home. Everything they say is yes. So we decided to, and then after looking at certain papers and reading certain literatures, we realized that no, it is good to do what the director was saying, actually do it well. So that's the beginning of our pregnancy school. So we have done the data for 2012 and 2013, and we started in April. So that's basically the reason why we started. And our stillbirth rate was still going high, and it was more of macerated stillbirth, as they die in their wombs before they come to labor.
Okay, so when you started and now down the line, what's the success rate?
Actually, what we did was we set 3 objectives. We decided to look at stillbirth, look at skilled delivery, and look at HB at 36 weeks. Because, like I said earlier, I mentioned the stillbirth rate, but another part that was a bit worrying was their HB at 36 weeks. You're having 6, 5, and 36 weeks, and you're going to labor. So, and you know that hemorrhage is second cause of maternal mortality. So it was close to our heart. And then we have 2 sub-districts. We have Dodowa sub-district and we have Osudoku sub-district. Osudoku is on the eastern part. As you go to Akosombo, it's on the eastern, on the right. I mean, when you see the hills, Shy Hills, some get to close to Ada. Some of them are quite rural. So their skill delivery was also low. And so they were delivering with TBAs and their aunties, and they were having complications. Sometimes they even die at home. We don't have them, their data being collected on them. They are lost they are lost statistics, as I call them. So there are 3 things that we're looking at, and we're happy to know when you look at the data for 1.5 years now, almost 2 years now, you realize that the HB at 36 has improved. I mean, 50%, it has gone down. And then it was like 55% when we started, like the number of women, that the percentage of women that had HBs below 11, 10 and down were 55%. Now it's 25%, and we're excited about it. And then one thing we realized was that the pregnancy school, we've had more than 500, as at 4 months ago, we had 540 that had gone through. So we're having almost about 1,000 and above that had gone through. So what we decided to do is to look at the number of cases, the number of clients that have passed through the school and their pregnancy outcomes. It was exciting to know that only 2 that had lost their babies. And the other one was a foodling breach.
Out of 1,000?
Up till now, it's only 2. Actually, only 3. The third one, it was booked for CS. We don't even know what happened. It was actually a staff, so we actually broke her heart, and she lost the baby. The other one was a footling breach, and was at home. It was like the first month when we started the school, and the other one was eclampsia, which is sometimes difficult to handle, and they lost their babies. So since then, we haven't lost babies.
There was a time when we realized that a lot of the pregnant women started reporting on they were coming bleeding. like this woman was referred here. They're coming bleeding. So you take the history and you realize that it's postcoital bleeding. Postcoital bleeding means bleeding after sexual intercourse.
Okay.
So the woman is pregnant and the man, they've had sex and she's bleeding. And then we talked to the man. It was like, when you have sex with a woman and she's bleeding, then it means you are a man.
Oh.
It shows the power of your, it's all right. I understand how you just felt about it. It shows the power of your manhood.